in their family. Next.
Yes. Hang on a second. I had to, that's my fault. Hang on. I had to, where are you? Oh, goodness. There you are. All right, next. You can't see that
See
now,
it?
can you?
No.
Yes. All right. Give me a
Sorry.
minute. No. You're good. Um, you're fine. It's me. Can you see it now?
Yes, perfect. All right, so how does it happen? So just a little flow chart. It starts with the lymph nodes enlarged, and the lymph flow in the submucosa is blocked. Lymph obstruction causes edema, mucosal alterations, fissures, abscesses, and sometimes granulomas. Mucosal ulcerations are called skipping lesions because they aren't continuous as in ulcerative colitis. And I'll show you a picture of that in a second.
Yes.
Overall, elevated patches of closely packed lymph follicles on the lining of the small intestines called Peyer's patches become inflamed. Next, fibrosis occurs, thickening the bowel wall and causing stenosis or narrowing of the lumen. Then what happens is the inflammation of the serous membrane develops, which is serositis. Inflamed bowel loops adhere to other diseased or normal loops, and diseased bowel segments become interprocessed with healthy ones. So they combine with the healthy ones. Eventually, diseased parts of the bowel become thicker, narrower, and shorter and can lead to formation of strictures. Next. Okay. What to look for? Malaise, diarrhea, bloody diarrhea is common in this condition. Pain in the right lower quadrant, generalized abdominal cramping and pain, fever, weight loss, anemia, fatigue, nausea, loss of appetite, and dehydration. Next is just a little chart with the symptoms on it. They can have inflammation, ulcers in their mouth, liver and bile duct inflammation, intestinal, they'll have problems like diarrhea, abdominal pain, cramping, ulcers in the digestive tract, rectal bleeding. They'll have joint pain and swelling. They'll have fever, weight loss, and a decreased appetite, vomiting, ulcers and sores, ulcers in the mouth, ulcers on the skin. Helpful hints in diagnosing Crohn's. To help you distinguish Crohn's disease from ulcerative colitis, Crohn's has skipped lesions on the mucosa, while ulcerative colitis has continuous lesions. Also, as you can see by the picture, I don't know if you can for sure, that it looks like a cobblestone. Linear ulcerations, edema, and inflammation causes the cobblestone appearance of the bowel mucosa in Crohn's disease. So that's what they would be looking at if they did a colonoscopy. And then here is the difference. If you'll see with the Crohn's disease, you'll see whether it's really, where the dark red spots is. See, it's blotching all over. It's all in different spots. Where the ulcerative colitis is all one piece. That's inflamed and red. Okay. Nursing assessment. We would get a health history first. We would get their bowel habits, how many times a day you have a bowel movement, color and consistency, experience of intestinal bleeding, their diet and lifestyle, other medical conditions, and the medication history, current and past. That's to find out if they've had a history of this before or if they have any other underlying conditions. Things to do for us would be complete vital signs, abdominal assessment, assess bowel movements, assess skin and pulses for signs of anemia due to the bleeding, assess for dehydration, skin turgor, You would start an IV, blood work, other tests, doctor's orders, etc. Know your abdominal quadrants. With Crohn's, it's the right lower quadrant is where you will see that. I'm correct with that, right? Right lower.
You said that.
Yeah.
Yeah.
Yeah. So it would be right in the lower quadrant. Like I said, in the small, and most of the time it's in the small intestines. Okay.
Okay. And you can see the colon would be more of your ulcerative colitis. So you can
Right.
see, this is nice. I like this. I like this. Very
Thank
nice.
you.
Yeah. That's actually a really good picture.
It's very good, I thought too.
Yeah. That's really nice.
Yeah. Well, because I had written out like what parts were in what, but then I found a picture and I'm like, okay. And I learned how to put pictures on a little bit today.
That's a great one. I actually really like it as well. Nice.
Very
That is,
useful.
yeah, that is. All right.
All right. Tests and what they tell you. Blood work. Findings typically indicate increased white blood count and an ESR, which is the erythrocyte sedimentation rate. That tests for inflammation. So does CRP. CRP does also. I'm not sure about what the exact thing is with CRP though, because I know it could be used for your heart too.
Yes, it's an inflammatory marker. It's an
Yeah.
inflammatory marker.
And they're looking for hypokalemia, hypocalcemia, hypomagnesia, anemia, and decreased hemoglobin levels due to the bleeding. A sigmoidoscopy and a colonoscopy may show patch areas of inflammation, helping to rule out the ulcerative colitis. So, like ulcerative colitis, like I said, they would be able to see when they did that. They could do a barium enema showing the string sign, which would be like the strictures separated from the normal bowel, which would help support that diagnosis. An upper GI series with a small bowel exam helps determine the disease in the ileum. And they could do a CAT scan also, which they'll see for masses or any, it's just to visualize the abdomen.
Yeah. And we're going to talk more about these different tests on Thursday, but this is great.
How to treat. We have to worry about the nutrition, so they can supplement with TPN helps to maintain nutrition while resting the bowel of a debilitated patient. Surgery can correct bowel perforations, massive hemorrhages, fistulas, acute intestinal obstruction. The patient with extensive disease of the large intestine and rectum may require a colectomy with an ileostomy, so that means they'll get the stump in the bag.
An ileostomy.
Ileostomy. Drug therapy. Effective drug therapy requires important changes in lifestyle, physical rest, restricted fiber diet, low in fruits and vegetables, and elimination of dairy products for any kind of lactose intolerance. You can use anti-inflammatory corticosteroids and antibacterials, and I listed two of them: sulfazine and mesalamine.
Yeah.
Metronidazole, which is Flagyl, which is a very common thing that they use for stomach issues. They use that too for like diverticulitis, along with an antibiotic, and it's something else. Antibiotic.
We use it for your H. pylori patients a lot, which some of these, yeah. So you have a protocol for H. pylori.
Do they use it for diverticulitis too? The Flagyl, I thought.
Absolutely.
Yeah.
Yeah.
So that's a very common drug to use with. And then there's the Lomotil, which helps with the diarrhea. But you can't give that medicine if a patient has an intestinal obstruction.
Right.
Immunosuppressant.
Why?
What?
Why would you not do that?
Because you're backing up your system. It has no way to go. It stops everything.
There's no, yeah, you're doing that, and you're preventing as well. There's a reaction with peristalsis as well.
Now, I'm not really clear. I have to say this. I'm not really clear on the immunosuppressants that they use. Can you explain that a little bit for me?
Yeah. So here's the thing with your immune system is going to start firing up in a response to what's going on to the body. So what's going to happen is it's going to start producing all of these cytokines. Remember, we've talked about cytokines and interleukins and things of that nature. So just like asthma or any other type of inflammatory process. So the cytokines and the interleukins go into effect and want to fight it. They look at all of this as a reaction that isn't normal. So they're like, hey, we need to fight that. Well, that's a great thing. But the problem is it fires up that inflammatory response even more. So we want to suppress it. So that's what happens here. So we create a suppression that immune response. That's exactly what's going on. All right. So that's, although the cytokines and the interleukins are the body's way of responding, we don't want that to happen.
Okay. And then infliximab, which is Remicade, it's a tumor necrosis factor alpha, which I'm not completely clear on either. It's to promote the closure of the fissures and to treat refractory Crohn's disease flare-ups. It's given in a monitored setting by IV infusion in a cycle of 3 treatments. And is that if there's a big problem going on?
So again, it's a similar tumor necrosis factors, TNF, is another component of this inflammatory response. They're all part, when we talked about in week, let me just go back for you guys. Hang on a second. I'm going to find it. Yeah. Week 3, we talked about principles of inflammation and immunity. And I want to say chapter 17, by the way, it says in here. And we talked about the body has your B cells and your T cells and how it fires up those different lines of immune response. And those, basically the B cells and the T cells create these lines such as your cytokines, your interleukins, your TNF, your tumor necrosis factor. So all of those things the body needs and the body responds to appropriately, but we use those and say, yeah, that's great, but we want to suppress it in some ways, or we want to utilize them so that they work in a specific way rather than randomly.
Okay.
A little bit like chemo.
Yeah, that's what I was just going to say. It sounds like it's like a chemo.
Yeah, exactly. All right.
Okay. So this is just basic things as a nurse we can do, or that we should do, we're supposed to do. Record fluid intake and output, including the stool, and weigh the patient daily. Watch for dehydration and maintain fluid and electrolyte balance. Be alert for signs of intestinal bleeding. Check stool daily for occult blood. If a patient is receiving steroids, watch for adverse reactions such as GI bleeding. Note that steroids can mask signs of infection. Check the hemoglobin and the hematocrit regularly. Check white blood cell count if the patient is on immunomodulators. Give iron supplements, blood transfusions, and analgesics as ordered. Watch for fever and pain on urination. Watch for a fever, and then watch for pain for urination, which may signal a bladder fistula. Abdominal pain, fever, and a hard distended abdomen may indicate intestinal obstruction. If they have to have an ileostomy, arrange for a visit by, I guess there's special therapists. I don't know if all hospitals have this, that are called interostomal therapist. Evaluate the patient. After successful treatment for Crohn's disease, the patient will maintain an optimal nutrition, hydration, and skin integrity, and use positive coping mechanisms to deal with a changed body image, as if they had to have an ileostomy. The patient should be able to identify and avoid foods likely to cause distress. Make sure the patient can demonstrate proper care of the ostomy if required, and use appropriate support groups. Evaluate understanding of the need for follow-up care and when to seek immediate attention. That kind of thing should be done, start going from the very beginning on educating them on what they have to do. Patient teaching is teach on the stoma care, talk about their body image, offer reassurances, emotional support, stress the need for a severely restricted diet and bed rest, which may be difficult, especially in a younger patient. Encourage patients to reduce stress and tension, because that's one of the causes of this. It aggravates it. If stress is clearly a factor, refer for counseling. Teach patient to follow the restricted diet, and they should exercise and seek family support. Patient needs to follow drug therapy guidelines and follow up with the doctor as directed. Report increased bloody stools or abdominal pain, and drink plenty of water. That's just some of the stuff.
That's awesome. What a phenomenal job you did, by the way.
Thank you. And I did a separate nurse care plan just based on this particular patient, which you guys all probably did the same thing, and I answered the question separately.
Right. Well, I think, first of all, you did a fantastic job. Don't you guys agree?
Thank you.
I mean,
yeah, she did a good job. Yes, it was a good, nice presentation.
Thank you.
Really, really nice. So before we go ahead, because I looked at Rhonda's and I looked at Evelyn's. I think, Kaylin, you just popped yours in, so I will look at yours as well. But let's just go over a couple of things. I'm not going to, because you all did the things, so I'm not going to go over delving too much. But what would be one of the complications of somebody who has some sort of gastric issue like this, with the potential for what? I mean, these ulcers could cause what? What could be a big risk, right?
Cancer?
Well, yes. Something a little bit more acute, though.
Bleeding.
Yeah.
And bleeding, because why? What's going on here?
Doesn't it also like
an ulceration?
Yeah.
So what could happen with that area if it's ulcerated?
It gets a hole.
Yeah. So what could be a problem?
Nutrition, digestion,
What if it creates a real hole or a fistula?
You have to have your intestine removed in that spot.
Yeah.
Right, but think about the acuteness of it. What could happen really acutely?
You could die because don't you get the poison
Peritonitis.
in your intestine?
Sepsis.
So where I'm going with this is, these types of patients can be at risk for things like peritonitis, right? I mean, if you've got an ulcer in basically small bowel or in the colon, and the ulcer goes all the way through, then you've got this fistula situation. Or, what if they've got ulcerated areas like the cobblestoning, and you decide to do a scope, and you could cause, unfortunately, you could cause perforation.
Right.
Because the tissue is more friable, isn't it?
Right.
So they're a higher risk for those types of things, peritonitis. And remember what I said with itis. Anything with an itis on the end is what? Inflammation.
Okay.
So you know when we talk about inflammation, you've always got an itis on the end of it. So and because of the way you're looking, this small bowel, you've got your little appendix. That was a great little side by side that you did with the differences between ulcerative colitis, itis, right?
Mm-hmm.
Inflammation of the what? Colon, right there. And then you've got the difference between ulcerative colitis and what was the other one?
Crohn's.
Thank you. Crohn's disease, which is your Peyer's patches, is sporadic, sort of going through the small bowel, as well as probably down into the colon as well. So they present slightly differently, and you may see more of a right lower quadrant issue with your Crohn's disease, whereas if you think about your anatomy, your colon is actually going to be more on the left side. So you may see more of a left-sided lower pain, left lower quadrant pain on your colon issues. Does that make sense? That's how I sort of try and look at it a little bit, because I think of it literally with my anatomy and physiology. And so that little picture is really helpful, I think, to help you sort of look at, okay, my liver's up here, so it's probably going to give me more right-sided issues. Obviously your other issues could be, ectopic pregnancies and things of that nature. But all of these different things, GERD, obviously, could be more of a hiatal type of issue. The reason I'm bringing this out is because in your HESI, some of the pieces that have come along are, GERD is definitely going to be there. I can tell you it's going to be there for sure. And we're going to talk about GERD on Thursday, but I do want you to be aware of that. But, these types of things could be on the list as well. Colon issues, peptic ulcer disease, all these type of things. So just be aware of them. And also, as I say, what you talked about, the immunosuppressants, that's a biggie. Steroids are a biggie. Antidiarrheals are a biggie. But then, of course, being aware of making sure you have to be careful, because some of these antidiarrheals have opioids in them. Opioids slows down that peristalsis even more. Yeah?
Yes.
So that's what we're being concerned about, that balance as well. What else did I want to bring out on some of this stuff? Let me see. Some of the things that we want to do as well regarding foods, right? With all of these types of patients, their nutritional status, it could be that we're looking at TPN. We may have to look at TPN, right? To rest that bowel, especially if there's surgery and it's intense, if we're basically cutting out some of that bowel, we may have to rest the bowel for a little while, depending on what's going on with the small bowel or with the colon. Questions for you, a couple of NCLEX questions.
I have one question for you. Yeah. Why do you get the ulcerations in your mouth if it's your intestines you're having a problem with?
Why do you get stomatitis?
Yeah.
Well, think about, for instance, what could be causing it. So some people get what are called canker sores. They're called, I can't pronounce it, but acanthus sores. So think about stress. So some people develop canker sores secondary to
Right.
stress, right? Also, some people develop, for instance, if they've had burns, they'll develop a form of ulcers related to, the stress, the physical stress that's going on in their body. So they may develop these canker sores that then develop stomatitis, those types of things go on. That makes sense a little bit? We're actually going to talk about that on Thursday, but that's a really good point. So it could be that they develop, or it could be, certain disease modalities rather. When I talk about H. pylori, H. pylori is secondary to peptic ulcer disease. Peptic ulcer disease, they have now stated that a lot of the times is stress, but it's also these H. pylori bugs, basically, these flotilla that go in the gut. So it could be many things that cause stomatitis, and it's not that they're separate, it's just they all work together.
Yeah.
You think about what's going on in the gut flora. Your gut flora isn't working properly, or if you're producing too much hydrochloric acid, that can affect it as well. Reflux, all of those things, which none of it works in a vacuum, right? You've got your small bowel and your large bowel, everything else connects, literally. So if you're having these issues in the small bowel and the large bowel, then you're probably going to have some what's called esophagitis and things backing up in that way as well.
Okay.
So a couple of questions for you. So think about what happens in the gut. Things like pernicious anemia, iron deficient anemia, right? When the gut isn't working properly, all of these other things occur. So patient has iron deficient anemia, and here's the difficulty that we're going to run into. The nurse determines the client understands dietary modifications if she or he selects certain items from the menu. One, nuts and milk, coffee and tea, rolled oats and fish, or oranges and dark leafy vegetables. Which one would that patient need if they have iron deficient anemia?
The rolled oats and the chicken.
Fish.
I would think the leafy green.
Oh, okay. But I thought they weren't supposed to have that.
Yeah, I wouldn't do the. Hello?
I would be eating plain.
Okay, so here's the thing.
I wouldn't eat the green.
Right, so I'm not talking about somebody who has irritable bowel disease.
Okay.
I'm talking about somebody who has iron deficient anemia.
Okay.
And you are right that somebody who has this ulcerative colitis, those types of things, yes, you want a low residue type of diet, more of a bland diet, loads of leafy greens. You're not giving these types of patients that you've just seen roll in with these types of issues, not going to give them the leafy green vegetables, absolutely, because that will trigger it, and citrus.
Right.
But your patient, this is the difficulty, right? Because yes, these patients probably do have iron deficient anemia, but we need to manage them probably. Maybe we're going to give them IM iron, or maybe we're going to give them IV iron, parental iron, because these types of patients, their gut isn't going to work very well anyway, so they're probably not going to absorb it very well.
So they probably wouldn't get like ferrous sulfate then.
So what was the
Because they
other?
can't
What was the other
digest it.
choices?
So what I'm letting you know is somebody. What I'm saying is just a patient who has iron deficiency. Ignore all of the superfluous. A patient with iron deficient anemia, what types of foods would you give them? You would give them the leafy green vegetables and the oranges, those types of things, okay? So I'm just saying that those are the types of patients, if they've just got iron deficient anemia and you did their blood work and it showed iron deficient anemia, you would give the leafy green vegetables. And the reason I bring this type of quick question out is because it's easy for us to try and bring in our knowledge base rather than just looking at the question. We're all guilty of that, me included. I'm going to go, yeah, but what about, they're probably not absorbing it and that and that. No, just look at the question. That's where I'm going with that, all right? Let me see what else I want to bring. But, you know, if it said somebody with Crohn's disease or somebody with ulcerative colitis that has iron deficient anemia, and it gave you the option of giving the parental iron or IM iron, those are probably going to be the things you want to look at for those types of patients. Can you see the difference?
Mm-hmm.
See where I'm going with that a little bit?
Yeah.
Okay. All right. Here's a good one. A client is recovering from surgery. They have advanced from liquid to full liquid. The client is looking forward to a diet change because they're bored with the clear liquid diet. The nurse should offer which full liquid diet item to the client? Tea, gelatin, custard, or ice pop?
And he's on a soft liquid diet, correct?
They are going from clear liquid to full liquid.
Oh, okay.
I would give the Jello. I don't know.
The ice pop?
They're going from clear liquids to full liquids.
Oh,
They
then
can
they
do
can have
custard.
custard. I was just going to say they can have custard then.
Yeah, remember, the patient's bored. Clear liquids, you're already giving them tea, gelatin, and ice
Right.
pops.
Oh, yeah.
Yeah.
Those are your clears. All right, next one. Yeah, I'm going to give you this one just because. Patient with cirrhosis. We haven't talked about cirrhosis. Cirrhosis of the liver. To minimize the effects of the disorder, the nurse teaches the client about foods that are high in thiamine. Remember, thiamine is a B vitamin, okay? The nurse determines that a client has the best understanding of dietary measures to follow if the client states their intention to increase the intake of which vitamin? Milk, chicken, broccoli, or legumes? What are legumes?
Something I don't eat.
Right.
Is it broccoli?
Legumes are not broccoli.
Oh, legumes are your beans.
Yeah.
Yeah.
Yeah. So, yes, you would want these types of patients to increase their plant-based foods, their legumes, those types of things. So, because, you know, yeah, those other things are great foods, but they don't have a lot of B vitamins in them, right? So I'm just throwing that one out there. All right. So, Rhonda and Kaylin, what do you think about this type of patient that came in?
For the case study thing?
Yeah. Question. Let me just, a couple of the questions I just want to. What type of things do you think that we can do? Obviously, pain control, but what other things can we do to try and help manage pain? Any ideas? Let me see what you guys put.
On my care plan, I had put some non whatever, however you pronounce it, like some other things to do besides meds, like positioning.
Mm-hmm.
You have more rest periods.
Yeah,
More
that's a
exercise.
great one. That's a great one. You know, how frustrating are we in the hospitals? We don't really allow our patients to
Very.
get any rest, do we?
No,
We don't.
we're
And
in
you
the
know
room
what?
all the time.
Yeah, and there is now a move towards having rest times where they say, you know, visiting hours are limited. They're not allowing open visiting hours. They're saying, say, between 2 and 4 p.m. Those are rest times for the patients and things of that nature, which is so needed. They'll darken the lights, they'll turn off the lights, do things to try and really facilitate rest and sleep, because that is one thing that is sorely missing in our hospitals, I think. So I
Yeah,
think
most
that,
definitely, because they're in and out, they're giving medication around the clock,
yeah,
so the patients really don't have time to sleep.
We're checking vitals. We check vitals every 4 hours.
yeah. And I think one of the things that they need to try and do a little bit more is blocking, meaning get everything done and patient rest, rather than this constant flurry of people coming in all the time doing all sorts of stuff. So one of the big offenders, I think, are pumps, IV pumps, you know?
Oh yeah, those things always beeping.
Yeah, always. So, all right, couple of questions for you. TPN, because we talked about TPN a tiny bit. Which nursing action which nursing action is essential prior to initiating a new prescription for fat emulsion or lipids, which go along with TPN? What do we need to do? What is lipids made of? Any idea?
Mm,
Fats.
What'd you say?
Fats.
Fats and eggs. What do we need to do? Do we determine the client doesn't have diabetes? Do we determine whether the patient has an allergy to eggs? Do we add regular insulin to fat emulsion? Or do we contact the healthcare provider to have a central line inserted for fat emulsion infusion?
Check for allergies.
Yes, we're going to
Yep,
check for
that's
allergies.
right.
That would be essential, right? A client is being weaned from TPN. They're going to start taking solid food. The ongoing solution has been reduced to 100 mils an hour. The nurse anticipates that the prescription regarding TPN will accompany the diet prescription. Okay, so do we just up the TPN? Do we decrease the rate? Do we start normal line, or do we continue the current rate? What do you think we might do? We're sort of weaning this patient. And that was the key term, weaning.
Reducing.
Yes. Decrease the TPN to 50 cc's an hour. All right. All right. A nurse is making their rounds at the beginning of the shift and they notice that TPN, the bag is empty. Which solution should the nurse hang until another TPN is mixed and ready? 5% dextrose, 10% dextrose, 5% dextrose in Ringer's solution, or 5% dextrose with saline?
I think is it just the
I
5%?
think it's D.
Is it 5% dextra and Ringer solution?
Okay, and what do you say, Kaylin?
D. The dextrose on the saline.
Okay, and what do you say, Evelyn?
I thought it was just the plain dextrose, 5%.
It would be the highest amount of dextrose, 10% dextrose.
It would be 10.
Yeah,
Okay.
yeah. Okay. All right. And think about this as well. These products have a lot of glucose in them. So if you didn't, what's happening here is if you don't maintain that, they become hypoglycemic very quickly. All right. So you've got to maintain that amount because the body's got used to this high amount of sugar. So if you then drop that in some way, they're going to become hypoglycemic. All right, and on that, think about this. There's a lot of sugar in these stuff. All right, a lot of sugar in this fluid. So a client has been discharged to home on TPN. With each visit, the home care nurse should assess which parameter most closely in monitoring this therapy: pulse and weight, temperature and weight, pulse and blood pressure, temperature and blood pressure.
What was the first one again?
Pulse and weight.
It should be the temperature and weight, correct?
Yes.
Oh, okay.
Because remember, what are we doing TPM for?
For malnutrition patients, so we want to update on weight.
Yeah, exactly. So
it's temperature and weight? Or just weight?
yeah, because no, temperature and weight, because we don't want them to get it. Remember, this is a medium, and that's what I'm saying, that glucose is a medium for what? Bacteria, right?
Okay.
So glucose, this is why our diabetics get infections and all the rest of it. There's a lot more sugar going on. So we have to be careful with that. So we want to watch their temperature, but we're also making sure that we watch their weight because we want to increase their weight. Yeah? Yeah. All right. So I think with all of that, I think that we have pretty much covered all of this. So you know the difference now between ulcerative colitis and Crohn's disease. Yeah?
Mm-hmm.
You think you know the difference? I think Evelyn helped us with that a lot. So Thursday, what we're going to do is we will meet at 8. I will send out an announcement because there's a few of you that aren't here. But basically we'll meet at 8 and we will do the exam proctored just like we've done before. I'll spend a couple of hours with you going over these chapters, which won't take very long. They're not big chapters. Okay, but be prepared on Thursday, that we're going to proctor the exam just like we've done before. You guys, I think, are used to that now. And as I say, I will send out a message, an announcement about all of that. Any questions, concerns? And then on Thursday, I will talk about meeting up. Well, we'll have clinical on Tuesday, actually. We'll have clinical on Tuesday, which will be
And I
reviewed.
registered for the meeting too, by the way.
I noticed that. Good job. So on Tuesday, what we will do is pretty much I'll just do some review with you. It'll be a short day. We'll do a review. And really what my intention is for you is to finish up your remediation, get that done, and really get some strong studying in for Thursday. Thursday, I think it's 10 o'clock, probably in room 180 again. Okay.
Okay.
So this Thursday, we want to meet at 8 o'clock in the morning for the test, correct?
On Thursday, yes, we'll meet at 8.
Online.
Yes, online. But be prepared. I need to see your desk and your area and all of that stuff, okay? So it's going to be a proctored exam. I will be watching you just like we've done before. Okay.
Okay.
And then next Tuesday, and then you're into week 10. You are done.
Woohoo!
Amen.
All right, guys. I will see you on Thursday. I look forward to it. Take care.
Have a good day.
Bye.
Bye.
And you.
Bye.
Bye.